The most common type of hyponatremia in clinical practice is hypotonic hyponatremia, which is characterized by a drop in the sodium content in the water phase of plasma and an overall true decrease in blood tonicity. In this, there are no other puzzling players. This is the real deal. We will discuss this in another lecture. However, there are two other often missed conditions known as hypertonic hyponatremia and isotonic or lab's fault error hyponatremia. This talk will cover both of these scenarios. So, a tricky and important question is on the way. Let's take an example. A patient's serum sodium drops to 128 milliequivalent per liter after IVIG administration. Is the hyponatremia here due to IVIG itself or one of the components mixed with it? IVIG is usually mixed with sucrose and maltose. The challenge here is to differentiate, is this hypertonic pseudo-hyponatremia due to sucrose effect? Or is it a lab error, isotonic hyponatremia IVIG effect, which is the same effect we see with high lipids, high bilirubin, and high protein? So I want you to pay attention here. Two ways to measure serum sodium in the lab. One way, called indirect measure, can sometimes make serum sodium levels look lower than they really are, especially when IVIG, high amount of protein or lipids, or bilirubin are around. But there is another way, called the direct method. This method gives us a clear view of the actual serum sodium levels without any distortions. So what you need to do here is call the lab and tell them, I need you to check the serum sodium by the direct method, then calculate the serum osmolarity by this equation to differentiate. Let's look deeper into this first scenario, hypertonic hyponatremia that results from sucrose or maltose-induced translocation of water from the intracellular to the extracellular compartment, as well as the infusion of large volume of dilute fluid in patients with an underlying defect in urinary free water excretion. By direct and indirect potentiometry or method, serum sodium will be truly low because there is another substance taking over, increasing the osmolality or tonicity. This is also seen in cases of DKA, severe hyperglycemia, post-TURP or transurethral resection of the prostate, where a lot of glycine is used. Also after mannitol infusion or high urea load. Here's another hidden player increasing the tonicity and making sodium look slow. If your calculation of serum osmolality turns out to be normal, meaning within normal tonicity or isotonic hyponatremia, then the cause is due to IVIG itself or a large protein load. Serum sodium will appear low by indirect lab method and by normal direct lab method due to increased percentage of protein or lipid inside the plasma with a normal plasma water sodium concentration, meaning lab error. You tricked the lab or the lab has tricked you, whichever you want to call it. Importantly, don't be tricked in the exam. To summarize all this, if isotonic hyponatremia, we're dealing with that lab error due to IVIG itself, hyperlipidemia, high proteins, high bilirubin, i.e. low sodium only by indirect method, normal by the direct method. On the other hand, sucrose, maltose, glucose, DKA-induced pseudo-hyponatremia, serum sodium will be low by direct and indirect method, or hypertonic hyponatremia. Lastly, correct serum sodium to glucose by this equation, meaning every increase in serum glucose of 100 mg per deciliter, expect a compensatory decrease in serum sodium of 1.6. Example, a glucose of 200, the actual serum sodium of 135 might result as 133.4. Thanks. Talk soon.